Okay, now we're going to talk about equilibrium, which is the other part of the ear function, still utilizing the vestibulocochlear nerve, except the vestibular branch. And you should know by now what vestibular means. And we have an apparatus. I like this apparatus, vestibular apparatus in the vestibule that has the utricle and saccule. This is going to be for static equilibrium, and then the semicircular canals, I like to call them canals or ducts, because the ducts are in the canals, are more for dynamic, rotational equilibrium. Okay, again, vision and this word called proprioception or proprioreception. Proprioception is your balance sense. Like a proprioreceptor is still a mechanical receptor that we have in our joints. Like the muscle spindle is a proprioreceptor. The Golgi tendon organ is a proprioreceptor. So it's all about keeping you balanced in space. We know there's all kinds of words, vestibular, equilibrium, but proprioception is the term used for the receptor. I think that's the best way to describe it. So static equilibrium involves the vestibule and the saccule and the utricle. And you should be able to point those out. It's not difficult. And that's linear. That's more, elevator, up and down equilibrium, like at Disney World or wherever you go, Six Flags for the Tower of Terror. And then you have the car going back and forth, right? Going forward and reverse. So that's more horizontal. So the semicircular ducts have those acceleration, rotational, in the vertical, oblique, I like to say oblique, and horizontal rotation, all the different ones. So now we're talking about static equilibrium. So now we're talking about the utricle and the saccule. So that is in the vestibule, of course, and the macula is the receptor. And that's what you have to remember. Like, okay, static equilibrium, macula in the vestibule, utricle and saccule. Okay, now this you might have heard of some of this stuff when it comes, again, we talked about vertigo before. So that's how we find out probably how these things work, by pathology. So again, a layer of hair cells in these receptors. And the supportive cells, kind of like a basement membrane cells. And here, look at it again. We have stereocilia and kinocilium, just like in the cochlea, in the spiral organ. But on top, you have otolithic membrane. All right, so now you got to think otoliths. Otoliths are stones. Lith means stone, the Neolithic age. So otto means ear, lith is stone. They're little crystals. Calcium carbonate, just like the stuff you're going to throw on the ice today. Right? So don't put that in your ear. Don't put anything in your ear besides your elbow, even though it's delightful to put a Q-tip in there. So the crystals shift within the membrane, and it bends this, again, mechanical, bending the stereocilia and the kinocilium. And toward causes depolarization, bending the stereocilia towards the kinocilium. You don't have to know this, though. This is too complicated. I'm not going to hold you to this about toward or away. I think that's kind of confusing. They probably just found out about it 50 years ago anyway. But this is the key. It's a mechanical stimulation. It's bending the hair cells, the receptors, the stereocilia, onto the otolithic membrane. And it causes what? Again, depolarization. Probably glutamate. But don't hold me on that one, because nobody knows. Okay? And that increases the frequency into the ganglia of the nerve. Again, you've heard of this, cranial nerve 8, except now it's vestibular branch. Right? And it says the opposite occurs. You have hyperpolarization, which stops the movement signal to the brain. Now that is important. I'm not trying to belittle this, because it's very important, because in some cases you don't want depolarization. You don't want to get sick and nauseous, right? Because that's the way you feel when you're at Six Flags. So sometimes there has to be hyperpolarization. And if you remember from nervous system, if you have hyperpolarization where the inside of the cell stays extremely negative compared to the outside of the cell, then you're not going to get an action potential. Sometimes you don't want an action potential, right? Because you want to hyperpolarize or inhibit a depolarization or action potential. And that really goes back to the nervous system, which hopefully you remember what that means, depolarization versus hyperpolarization. So depolarization is action potential for sure if it reaches threshold, and hyperpolarization is like almost no way to get an action potential unless it's really, really strong depolarization. Refractory, all that stuff is involved with that kind of a thing. So now we're in the vestibule for static. Remember, static equilibrium in the vestibule, utricle more on top. And these are tough to see, really. You can hardly see this. And one more back towards the cochlea is the saccule. So kind of know where they are. And here's the nerve. Of course, the vestibular branch. Here's the cochlea, which is shaded out because we already talked about that for over an hour. So look at the different rides on this roller coaster at Six Flags, right? There's 3 semicircular ducts or semicircular canals. And same thing, look at the inner tube. It's a good drawing there. Now we can see that a little bit better. The bicycle tire with the inner tube. So it's still bony on the outside and membranous on the inside. And there's fluid, perilymph on the outside of the membranous, and the lymph in the inside of the membranous duct. That's it. So anterior looks more vertical. Posterior is oblique, although you can't really tell because it's a 2-dimensional picture, maybe in the 3D. And the horizontal is more in the middle. Okay, so posterior is kind of like the angular one. Anterior is the more vertical. So that's stuff we should know, again, for an easy question. Come on, get these points. Don't lose these points. Just anatomy, right? Here's a close-up of the autolytic membrane and the hair cells and the kinocilium. Look at the little autolyths, the little coffins. Kind of like kidney stones, too. So kidney stones are calcium carbonate. The stuff you put on the ice is calcium carbonate. Now you have these little crystals. So these little crystals, they're kind of throughout this gelatinous layer of the membrane, and they move around a lot. Sometimes they get stuck in the wrong position, and you can get vertigo if one of these autolyths is bunching up or creates too big of an autolyth. And that makes you dizzy, which, again, we get vertigo. They have this condition, let's see if I get it right, benign positional, I think it's vertigo, or BPV, but it's positional, benign positional vertigo. It has to do with the autolyths. So this is benign because it's not a problem technically with a brain tumor or nerve or conduction issue. The problem is when you lay down on your right side or left side, these autolyths kind of shift out of position and cause too much depolarization of the nerve, and you feel like you're spinning, and that's vertigo. All right, so they call that benign positional vertigo. There's another letter in between. I think it's an H, but I'm not sure. I don't remember. So you can actually get that treated. Like you can go to a physical therapist, and they'll put you in a position to reproduce it, which is really scary. It's called the Dix-Hallpike test, where they kind of bring your head back and turn it and extend it to see if you can get that autolyth into that position and make you sick and dizzy. Oh, so now they found out, okay, now that's what's causing this benign positional vertigo. And then they keep working on it to keep moving your head in the opposite direction. And you do a treatment to try to stabilize that autolyth. And it does work. It cures the vertigo, because vertigo is a horrible condition. You feel like you're going to fall over every time you move your head in one direction, if it's positional. Now, of course, that I'm talking about benign positional. Now, if you have vertigo all the time, it's a really miserable situation, whether it's coming from your inner ear or if it's coming from something else. There's a lot of causes for vertigo. Vertigo is just a sign and a symptom, really a symptom, but you could see it and somebody's falling over. They can't walk straight. And it's a terrible thing. But the autolyths being out of position in the vestibule, static equilibrium, really scary. You don't want to go on an elevator. Driving in a car would be impossible. So again, showing a nice schematic of the membrane, close-up of the cell, hair cell attached to the nerve, which goes to the ganglia for the vestibulocochlear nerve vestibular branch. And it moves in different directions. You don't really have to know that. Just know the again, we already talked about kinocilium and stereocilium, but now we got autolythic membrane in the vestibule for static equilibrium. That's not for hearing, right? The tectoral membrane was for hearing. And that's what you should know, the difference between those. I'm sure it's written out in your checklist. Again, these are moved or activated, and movements like this, just flexion and extension of the head is a good one. No rotation though, because this is not rotational, this is linear. This is up and down or front to back. So angular acceleration now, like now we're in Six Flags, we're really moving now, right? Let me see if I can draw on this. So this is angular or rotational. And now in the semicircular canal, you have a region called the ampular. So ampulla, and that is a big structure, it's an important structure, and that's about angular acceleration. And within the ampulla, you have the crista ampullaris, and you have, again, stereocilia and kinocilium, which this is multiple, and they're embedded into what's called the cupola. And you'll see a picture, and I think that's important. You see the pictures of all the three. Like this is rotational angular acceleration. It's the ampulla and the cupola. The static is the utricle satrical macula in the vestibule, and hearing is this spiral organ, right, from the cochlear duct with the tectoral membrane. I think those are all important. Three things that you should be your takeaway from this lab. And again, you can go back to the atlas and see it in MH Connect. So look, here it is again, endolymph in the inner membrane, presses against that gelatinous cupola, and it bends. Again, here's the mechanical part. The mechanical receptors, not chemical, not photoreceptors, not temperature or pain, noceo, or these are proprioreceptors. They are proprioreceptors though. So that's important to know that these mechanical, like the receptor is mechanical receptor, and a type of mechanoreceptor is proprioceptor or receptor. So just like the joints, synovial joints in your knees, these are in your ear for sense of movement, mechanical. But proprioceptor has to do more with balance. And if you remember, the cerebellum has to get involved. Remember the cerebellum from AP1 is all about controlling balance. Like when you're on a balance beam, you're using your cerebellum as a gymnast, and you're also using your inner ear, your vestibule, and your semicircular canals, depends on what movements you're doing. So they're all in your brain has to be wired together. I think that's another takeaway. And I don't think you're going to forget cranial nerve for both of these, cranial nerve 8, right? And what stereocilia is, hair cells, and kinocilium. That's going to pop up at you. I think we said that enough, right? So hyperpolarizing is going to prevent an action potential, so you're not going to feel sick and dizzy. And there's a neurotransmitter again. Which one you think it is? Probably glutamate. It's not acetylcholine. It's definitely not norepinephrine. It's not serotonin, not dopamine. So it's most likely glutamate, because glutamate is the neurotransmitter that's released in the eye as well. So whenever you hear special senses, if you're a nursing student, you're taking an NCLEX and they mention a neurotransmitter, you're probably going to think glutamate. But the problem with glutamate, it's more of it's kind of contradictory, because glutamate in special senses is more of an inhibiting neurotransmitter that causes hyperpolarization, where in the brain, it's the most abundant excitatory neurotransmitter in the brain. If anybody who has anxiety knows that, or anybody who has terrible condition like ALS, or something that causes toxicity. So glutamate should ring a bell to you in special senses. Here's the cupola. There it is, Francis Ford cupola, right there. There's the gelatinous membrane, and there's your kinocilia in it, stereocilia. And again, as you move, the two different parts of this apparatus, static and dynamic, or acceleratory, or angular, I should say, is going to bend the stereocilia, which moves the kinocilium, and then the hair cells. And the hair cells kind of stay still as the kinocilia kind of move, like cilia, they kind of flow this way, and then they'll flow that way. like cilia that was moving things. But these cilia are really microvilli. They can call them the same thing, but I don't want to split that hair. Split that hair. Do you hear that pun? But it's more for mechanical movement and how it interacts with the cupola. And the cupola will send the signal back to the nerve, which is the vestibular branch of the vestibulocochlear nerve, cranial nerve 8. I'm sure we got that down. So look at this. We got a still cupola, and no movement. And here's the movement as he's rotating his head. So your brain has to react. So the neurotransmitter will send the signal to not make the head keep spinning, right? It stops that feeling of spinning. Although if you've ever done this before, if you keep spinning around, it takes time, right? It takes time to kind of balance yourself out and right your feeling of spinning. If you've ever been on a ride at Six Flags, or if you ever put your head down and just spun in place, you know that your brain has to catch up to it. Some faster than others, depending on the neurotransmitter release, depending on the ear, like how the ear is functioning, if there's any other issue, if you have a virus at the time, if you have a bacterial infection that's affecting your inner ear, which can happen. The viruses will destroy some of this vestibular and cochlear structures within the inner ear, not just the middle ear, like in the babies. So that's another big thing. So I don't think we have to mention this again, but again, cranial vestibulocochlear nerve. And again, it's in the medulla. The nuclei of the vestibula is in the nuclei. The nuclei is in the medulla oblongata. But I think some of it goes into the pons too, if you really want to look at it. But don't worry, just say medulla oblongata for this nerve. And then I mentioned the cerebellum helps to coordinate the balance and the muscle tone. And again, the thalamus gets involved because all sensory information has to go through the thalamus. The thalamus is a relay station. All right, and then to the cerebral cortex, which you're going to find out again, it's the temporal lobe of the cerebrum that deals with and associates your balance. And here it is. The cerebellum is posterior, right? So you have input from the cerebellum through the olivary nucleus again. And then you have your thalamus. I'm not sure what nucleus, you don't have to know what nucleus. And then up to the cerebral cortex. Let's go through that again. Yeah, that's pretty much it. So the cerebellum is something you might want to add to your bag of tricks here. Let me just see what's coming next, just the question. So there's another thing I want to show you, an interesting thing that happens to people, and even with the otolithic problem. You see these cranial nerves that are they're very close. The nuclei is very close to the medulla and the pons and the midbrain, but mostly medulla. Like cranial nerve 3 is oculomotor, which is about eyeball movement, right? And dilation or constriction. And then you have cranial nerve 4, which is abducens nerve. I'm sorry, trochlear nerve. Trochlear nerve is cranial nerve 4, and it's all about moving just one muscle of the eye. Like, you know, your eye moves in an H, sort of, and it has oblique muscles too. And cranial nerve 6 is abducens. And they all kind of get mixed together, those nerves, cranial nerve 4, cranial nerve 6, cranial nerve 3, which are eyeball movements. So sometimes when you get dizzy or you have vertigo or you have a problem with your inner ear, you get what's called nystagmus. And that's, I think it literally means dancing eyes. I've seen people with this. And it might not have anything to do with moving the head, but usually it does. And their eyes shake, like side to side, at rest. It's very strange. And, you know, it must be really uncomfortable for the person or the patient. So nystagmus is a problem, really it's a vestibular problem, but because of all the crossover in the medulla oblongata of this nerve tissue and nuclei, that it affects the contraction and depolarization of those nerves going to the eye muscles, the extraocular muscles that move the eye when you look to the left, right, up, down, side to side, oblique, straight, and to the left or right. So nystagmus is another condition. I don't know if it came out in your lab. I don't remember seeing it, but it could be. Should be. Okay. So any questions about any of this?